Good afternoon, everyone. Welcome to the Institute of Medicine of Chicago. My name is Deborah Hodges. I'm the Association Manager and Program Manager of IOMC. It's my pleasure to welcome you to today's session and introduce our speakers today. And thank you so much for being here. Today's session addresses how the Institute of Medicine of Chicago will be actively involved in creating systemic change and advancing the maternal health and child efforts in the South and West sides of Chicago. IOMC formed a work group to address these challenges of young and at-risk pregnant women in the Chicago area. When the Institute of Medicine presented its State of Health of Chicago program in October 2021, IOMC knew it would designate resources to change maternal health inequities. Numerous studies, as you know, have documented the critical need for access to prenatal care and reduced use and reduced access to pre and postnatal care. There is a long list of women's health disparities from stillbirth to infant and maternal mortality. And while today we cannot effectively address all of the problems at once, we can prioritize them and implement the necessary changes to make improvements. So IOMC today intends to address and answer how to improve access to care in selective communities, improve access to level 2 care, and more. And according to the National Center for Health Statistics, in 2020, the maternal mortality rate for Black women was 55.3 deaths per 100 live births. The 2020 rate for white women was 19.1 deaths per 1,000 live births. There are many issues that factor into these statistics and improvements that are greatly needed. So this program is part of IOMC's programmatic series on public health, population health, and community health, reducing health disparities, achieving health equity. With us today are three wonderful speakers. We are very proud to have two of IOMC's board directors leading today's session, Dr. Anita Stewart and Dr. Lisa Green. Both are physicians leading the Maternal Health and Child Workgroup as co-chairs. Dr. Stewart is the Medical Director of Government Programs with Blue Cross and Blue Shield of Illinois. She is also a Billings Fellow of IOMC, and as I mentioned, a board member of the Institute of Medicine of Chicago. She has practiced as a pediatrician for over 10 years and as a clinical assistant professor in general pediatrics with the University of Chicago. Today, in her role with the Blue Cross and Blue Shield, Dr. Stewart is affiliated with the Rosalind Franklin University, and she holds a master's in public health and a doctorate in law as well. Joining her today is Dr. Lisa Green, who's the Chief Executive Officer at Family Christian Health Center. She is an IOMC Fellow and a board member of the Institute of the Medicine of Chicago. Dr. Green is also the co-founder of Family Christian Health Center and has been a physician at the health center since it opened its doors in 2000. And Dr. Green has more than 16 years of experience practicing family medicine and providing leadership as a physician and executive. And prior to her assuming the role as the CEO, Dr. Green served as the center's chief medical officer. Dr. Green holds a master's in public health and a doctorate in osteopathic medicine. And they are joined today by Ms. Dawn Gay, who is the executive director of Care Advisors and a fellow of IOMC. Ms. Gay is the chief relationship officer of Care Advisors. She is a fellow of IOMC since 2021. And she is a member of the Maternal Health and Child Workgroup. She's currently working on her PhD in values-driven leadership, and she holds a master's in business administration and healthcare management. So I hope you welcome me today in regards to these three outstanding women. More information on all three of the leaders, the speakers today, can be found on the website. Their resumes, their CVs are very lengthy, and I know you'll appreciate all of the work that they've done over the years. What we'd also like to do is to recognize all the members today of the Maternal Health and Child Workgroup. So we're displaying their names on the screen right now to you. James Kiamos, Dr. Cheryl Rucker-Whitaker, Deborah Savage, Dr. Simon, and Dr. Sullivan as well. And if you'd be interested in joining this work group, please contact the IOMC office for more information. Today's program includes an agenda where we are in the process right now of our welcome and introduction to you. We're going to talk, just let you know about 2 or 3 programs that are coming up at IOMC. We have a wonderful presentation for you today. There'll also be a question and answer session that will be approximately 10 minutes or more so that you can answer, we try to answer as many questions as we can today. So by attending this session, the learning objectives that we hope that you will take away is you'll obtain the key disparities that IOMC is going to be addressing over the next 2 years and be able to identify the intended actions and timeline that IOMC's work group has defined and see how they relate and align with advancing maternal justice through clinical care practices. If you are brand new to IOMC, let us tell you just a little bit about our mission. The Institute of Medicine of Chicago is an independent, nonprofit organization of distinguished leaders in the health field who collaborate together to improve the health of the public. There are many diverse members and other regional leaders that are involved, all get together and collaborate on critical health issues like they are today through a range of interdisciplinary approaches through education, research, and sharing trusted information with each other and actively involved in community engagement. IOMC is a 501c nonprofit organization. Before we begin our presentation today, I want to let you know that there will be a webinar on March 10th, and it'll involve with 4 key speakers. And the topic is resistance to adopting childhood vaccines. Is this a rising public health issue? The interest in producing this particular session is after COVID, there has been a lot of discussions on whether or not vaccine, especially childhood vaccines, are helpful, needed, and necessary. So I hope that you will join us on March 10th for that particular session. Also, I want to point out to you on June 22nd, we will, IOMC will be hosting its Healthcare Awards celebration, which will be held at venue 610. And we hope everyone will look at that date and attend as well. So on an average, there is about 150 attendees who attend that particular celebration and honor people who have really made a difference. The nominations for awards is open at this time. More information can be found on IOMC's website. So right now, I am going to turn this over to Dr. Green so that she could give the overview and moderate the panel for today's discussion. So Dr. Green, it's all yours.
All right, thank you so much, Deborah, and just for all the work you do, you know, behind the scenes, putting this together for us, especially for this important topic. I am so grateful that everyone has tuned in. We've seen in the news media, unfortunately, far too many times, what we have seen in our communities, especially for Black women and maternal child health. It's now reached the elevation of the White House. So you have been able to see throughout the country, unfortunately, due to bad outcomes that have occurred in our communities. And so what we'd like to do today is kind of level set for you, you know, just the reality of where we are with things and how we want to begin to tackle, to look at ways that we can improve some of those outcomes. So what we do know for facts already is that Black women are more likely to die from pregnancy and child-related than in birth or than any other race. We also know that they're 3 times more likely to experience a pregnancy outcome that is not favorable, also more likely to die from preventable deaths. And that's one of the reasons that we're here today, is because a large number of these deaths that occur are actually preventable. And so all of us as a country own this as part of our communities to ensure that we are providing the most equitable and quality health care to all of our citizens. So when we look at Black women's the death rates that occur. What we also know is that education and economic background have not also served as a protector for some of these outcomes. We do know that African-American women, Black women, have more chances of having fibroids, display signs of preeclampsia. So there are a lot of pre-existing things that occur in African-American women. What we also realize is that under a report from the Journal of American Heart Association report was that 45% of African-American women were more likely to die in the hospital at a much higher rate from heart disease. The other piece is that we know that a lot of the complications that occur are not just during that 9-month window, but they occur after up to 1 year after birth. Go to the next slide, please, Deborah. So when you look here at Illinois and you look at this slide, the whole purpose of this is for us really to take a deeper dive into, we know it's a national crisis, we know each state, but what are we doing here in Illinois? What do our numbers look like? I mean, we are grateful that we have so many different task forces now that now see this as an initiative over the last several years to really raise awareness and action to be able to mitigate this. But if you look at one of the charts that really is alarming is that it says on average 75 women each year die while pregnant within 1 year of pregnancy. But if you map that out, that's 1 death every 5 days. And we just said that a large majority of these can be preventable, which is again, the reason that we're having this discussion today. About 1 in 3 pregnancy-related associated deaths were also again occurred within African-American women. The other issue is the timing around pregnancy-related deaths. So when you look at what I was mentioning earlier, is that a lot of these deaths also don't happen just during the pregnancy, but they happen in that postpartum period as well. We also know that Black women were more likely to die based on other pre-existing conditions. And so we all now use the term social determinants of health. So what is that, right? And so it is because sometimes it is the economic barriers that they live in. It is also because of the lack of care in certain areas. So many of our patients live in food deserts. The education, even though we know that's not a protector, you couple all of those things together, it has really not level set a fair playing field. And so our goal today is to really kind of do a deeper dive in what we can actually do to be able to mitigate some of these problems. Next slide, Deborah. So priority and specifics. I just talked about so many different things, right? So where do you start? You know, there's so many different avenues to this, but as we just continue to talk about it, how do we begin to move the needle to make things happen? And so that's what I'm very grateful for, the opportunity with IOM and the team members today to begin to level set again how we begin to do that. So we look at the priorities. And so for us over the next 2 years, we rank them. So OB care networks and not having access to level 2 ultrasound on the south side. What does that mean? We just talked about how some women that are pregnant have so many other conditions pre-existing. And so it puts them in a higher risk. That means they need access to not just a regular ultrasound, but a level 2, which is a more detailed access. And all women don't have access to that within the areas that they live in and have great communication to be able to get transportation and connecting them to those services. The other piece is that there's a lack of OB care in several areas. We noticed during COVID, we had in areas that were already short for hospital deliveries. During COVID, some of those hospitals closed their doors, but one has since reopened. We also know that besides the transportation, we have to promote the need for implicit bias training, on all levels across. And that starts with medical education, and all of us. The other thing is that we identified that we have to address what we call phantom networks. So you have this list of providers, but then you go to try to network and connect patients to them. And by the time you do that, that particular provider isn't available at taking new patients. And so you start that process all over again and delay the care that these women actually need. The other piece is that you have to expand the bandwidth with mental health issues. COVID had a huge impact on all of us. So imagine women who are already living in conditions that have put them in a high risk category. And now post-COVID, just some of the stressors, that is whether it's financial. We were just talking the other night, gas, the price of eggs. There's so many things that are happening right now. And so we realize there is more anxiety and depression across the board than there has been before. So we have to be able to take a look at that. The last thing is that we prioritize educating others and the state really now knowing that on how do we put services that are actually available to the providers and to the patients for that network. Next slide, please. And so what I'd like to do now is turn it over to Dawn, who is I call the guru of data, to really begin to help us take a deep dive into how we're going to map this out.
Thank you, Dr. Green. I appreciate that. Thank you for allowing me to participate with you. This is a very exciting opportunity. And although we have many health disparities on both the South Side and the West Side, you can't change everything all at once. So this map really depicts our focus initially. So we have chosen to work with Family Christian Health Center, which is a federally qualified healthcare center in Harvey. Dr. Lisa Green is actually the CEO and co-founder of Family Christian Health Center. So if you look at the map in the center where it's the darkest blue, that is the location of the FQHC, and you have primary care service area as well as secondary kind of mapped out. But I think the interesting part of this is when you look at the zip codes, and this is just in the last 6 months, we actually had 299 patients that were actually being referred from that primary service area on the right side of the map, and on the secondary, 150. That's quite a few patients that are referred for ultrasound. So just to kind of give you an idea, we just wanted to depict the importance of our focus, where we want to eventually impact change. And that's really important as part of the study, is really determine and have factual data that we will be able to go and make the next determination of what are we going to do to change it, because it definitely has to be changed. Next slide. I think too, the demographics are extremely important. And 77.28% of this patient population belongs to the Black or African American population. Again, huge disparity on the South Side. So I think the other thing that's really important too is in the service area that we're working with, and this again is the last 6 months of ultrasound referrals. You had 236 in the primary service area and 111 in the secondary service area. Next slide. So what's really, really important based off of this is currently where the practice is referring to get ultrasounds, level 2 ultrasounds. And interesting enough, the 3 primary hospitals that are getting most of the referrals is the University of Chicago, which received 66, Advocate Christ, which received 61, and University of Illinois Health, which it was 57. Now, as we move forward, we know that we're going to be adding more hospitals onto this, but I think it's really important. We'll determine the reasons, a lot of the proximity, but it's still very hard for patients that live on the South Side to travel to these facilities. So the one thing that we're really focused on is transportation. And there's many, many reasons why we chose to start with this, is because it's such a high-risk population that needs to get level 2 ultrasounds. Many of them are on Medicaid managed care programs, and there's a lot of rules and regulations. And a lot of times a simple thing where someone, from an age perspective, and they have different rules for transporting minors. If it's a single mom that is trying to go and she needs to get a level 2 ultrasound, but has another child to take with, that's not covered. So that's just one example that we're going to be looking at for different options to make it available. This is a problem that really needs to be addressed. So we're very excited to be part of it. And I know we're going to do a lot of research in this area. And we're very excited that we have an excellent federally qualified healthcare center to participate in this research to give us the data that we really need. And then we'll expand it out from there.
At the Centers for Medicare and Medicaid, and just some of the priorities, One of the things that you see listed out here is that in 2020, approximately 26.3 of C-sections were among lower risk women. And so what we talked about earlier is a lot of the complications that we're seeing are things that are preventable. So that's why this work is so imperative. And part of the initiative through CMS is to increase the use and quality of postpartum care visits, to increase the use and quality of well child visits, because we didn't even go into what happens with low birth weight babies and some of the other complications that occur. Again, trying to prioritize and then be able to make effective changes kind of one bite at a time is the reason that we didn't go into complete details with everything else. But the other initiative is to decrease the rates of cesarean section birth, C-section birth, especially in low-risk pregnancies for first-time pregnancies, full-time, single, or a vertex birth. So the work that we're doing is really important, not just because here locally, but it's really the initiative on a national level as well, that to try to make positive changes for women, anything that we can do that will decrease and bring those numbers down. Remember that map, 1 in 5, right? So you can say 75, but that doesn't sound like a big number. But for those 75, that's somebody, which we always realize, that 1 in 5 that dies here in Illinois, that's somebody's mother, sister, aunt, cousin, neighbor. And that's why we're doing this. So part of our timeline is what you see here. Again, how you take the elephant. You can't bite it all at one time, right? But how do we bite it out a bit, one at a time? And it's amazing working with the people on this call and at IOM, because we've come together with a timeline. All of us want this solved yesterday, right? We want this solved yesterday. We don't want the 1 in 5 days anymore. We want that 0. But it's going to take collaborative efforts. We know that at the state level, the city, the county, all of us working together to get this done. So our goal here is over the next 3 to 8 months is that we're going to take a deeper dive into looking at really those access for those level 2 ultrasounds and the lack of OB care in specific patients and what that transportation does. And I will tell you, for people that live in the far south side and the southern suburbs, they have to access the PACE system before they can even come to the city. So when she listed that a third of our patients in particular go to the University of Illinois, that could be 2 hours on public transportation, and that's one way. Now, and don't have another baby or a stroller or get hungry because you need to get something to eat on the way. That's a whole nother story. Or need to drive, but you need gas to be able to get in the car to drive that far. And people are afraid for so many different reasons now of driving, of, just carjack, just some of the trauma that is happening, in our communities. So all of that is impacting us. But again, can we fix all of that at once? No, but this thing we can do. And what we realize as we begin to chip away at this, it's also going to go into other areas that we believe will help. Next will be over the next 9 to 12 months, and that is to promote the need for implicit bias training. And so we all now, it's been diversity and equity. We've been hearing about that since Black Lives Matter, right? But now how do we drive down and drill down to at the MCO level, at the state level, at the medical education level? What does that look like? And our goal is to really have materials that are tangible, not just a policy and a 5-minute presentation that says this is what you do, but in turn, really develop a tool that people can own and understand what that looks like in action. And then between 12 to 19 months, we'd like to take time to really sit down to see why do these what we call phantom referral networks look like. We know that's not the intent of the of the health plan, right? To give a list of people that we know don't take the plan or they're out of business, but somehow just with changes in life and communication, what happens is when that coordination doesn't happen at the top end, the people at the other end feel the brunt of that. And so that is the reason that over these next 12 to 19 months, we'd like to engage in conversations and develop what we call network of policies to really review and take a deep dive into the actual problems that cause this. And how do we then come up with solutions, and partnership that are tangible and that can be scalable and duplicated. The last piece is over the next 12 to 24 months, is really educating everybody else. Right, it's that continued education, because as we know, things change throughout life, priorities change. But what we want to make sure is that this elevation of voice for that 1 in 5, that 1 in every 5-day woman that dies, that in 12 to 20 and 20 to 24 months, we're not having the same conversation. And so that's really the goal for this. So the current initiatives now, I will ask Dr. Stewart to step in.
Thank you, Dr. Green, and Ms. Gay, thank you as well. Deborah, you can go to the next slide. What I'd like to do in just these few slides is sort of summarize what Dr. Green and Ms. Gay have already said. The problem is not just on the south and west sides of Chicago. It is also a nationwide dilemma. And it is not just social determinants of health, but it is also what is called structural racism at play. And minority women, Black, Hispanic, Asian, and a Native American are all involved. You see the numbers here on the slide. Many, as Dr. Green pointed out, are preventable. The issue that I take to heart is that everyone in healthcare, especially as a physician, takes an oath to do no harm. And every physician has a role in advocating for their patient. So the question becomes, how do we advocate for our patient? For me, it is very deeply and personally felt that we improve healthcare as it relates to the population maternal child. I don't really want to repeat the numbers, but infant mortality in the US is quite high. And one of the things that Dr. Green pointed out earlier was the C-section rate, and that is preventable. In some instances, there were women who had C-sections that were low risk individuals. And there actually have been studies that show that the number of C-sections increase weekends and evenings. And we've looked and worked with organizations where their OB staff were very invested, in which they actually look at the C-section rate of their department, and the physicians actually go over the indications for a particular C-section to ensure that a C-section is appropriately done. When we talk about maternal mortality rate that has increased to 26 deaths per 100,000 in 2015, and a mortality, and while worldwide the mortality rate has decreased by 44%, this is a much larger problem. And if you look at it, many women, because they are considered at that age group healthy women, they're not being screened for conditions that are preventable. For instance, hypertension. Many women are borderline or truly have hypertension prior to becoming pregnant. Women who have family histories of diabetes, we're not picking up early. So some of the things that we see are preventable from the standpoint if we were able to treat these patients early. We're not finding them until another condition occurs, which is the pregnancy. One other condition that I'd like to mention is maternal health. Another disease process that doesn't get the attention and brings in several factors that Dr. Green spoke of earlier. Depression, anxiety, very high, but does not get the attention it deserves because not enough providers, quote unquote, phantom networks where providers at a particular point in time do not have the access to accommodate a particular patient, or lack of services within that community area. Another thing not mentioned is substance use disorder. Not only is there the stigmata attached to that, but I don't know if you've ever thought about it, but on the south and west sides of Chicago, there is a plethora of methadone clinics, but few that prescribe Suboxone. And when you are talking about the use of a methadone clinic, that requires that you go a certain number of days of weeks, a certain number of days. And then if you are quote unquote, have clean drops, you are allowed to have carries or to take methadone home, but that is not an easy phenomena. It disrupts your life. You can't plan around it. So that is an issue. But if you look in other communities, especially on the north side, there are a greater number of providers who prescribe Suboxone. So another inequity. This is just to give you some idea about the complications that we can see. I think Dr. Green spoke of the fact of eclampsia, preeclampsia, bleed outs or hemorrhages, the need for blood transfusion with also a hysterectomy. And then of course, even some conditions in which patients must be ventilated. And that is just to show you the severity of the conditions leading to maternal morbidity. Okay, so with that in mind, let me just sort of summarize what we're trying to report out on and why we're doing it. There is an issue in our community with maternal and infant mortality and morbidity. And if not us, who will do it? We're asking for support, but we want everyone to become involved because it is something that we can make an improvement in. We identified a service area, and Dr. Green and Ms. Gay spoke of this earlier. That service area was based on what the data led us to. There are other communities, especially when you look downstate Illinois, where there is not much access OB-wise at all, that is equally important. But we chose to tackle what was in our backyard, what we had access to. So hence the service area chosen was the south and west sides. We also chose that area for another reason, because we are familiar with that area, either because we have worked in that area, do work in that area. We know that there has been a significant change in access. We're talking not only about the OB providers, but also the hospitals that provide OB care. So that was another issue for us to tackle. Lastly, when you speak of referrals and hospitals, the issue here is that many times the kind of care that you need is what we call tertiary care. And tertiary care can't be obtained at every hospital, nor do we have those facilities in the areas on the south and west sides that could readily accommodate us. When we say tertiary care, we're looking for specialized OB care that deals with high-risk moms, for instance. And that means you have to go to, say, a University of Chicago or to a U of I or to an advocate. Now, remember, everybody is trying to use these facilities. Thus, it's going to be a wait list, and in many instances, time is of the essence. So the other issue becomes one of referrals. It depends on what insurance you have, whether or not the health plan or that particular hospital, I should say, takes your type of insurance. And in some cases, it also means that the OB provider will also have to do a pre-authorization, an additional step. So we have to take all of that into mind when we try to care for women in these particular communities. Dr. Green spoke earlier of the transportation issue. Also, when we talk about transportation, we know that in Illinois, women are considered emancipated with pregnancy and mental health conditions. But you saw from her slide that still consent is required. This may be difficult to obtain consent from a parent. And lastly, what I'd like to point out is that Dr. Green spoke about implicit bias. There are issues that patients see with their healthcare providers that usually go silent. Provider never hears it, and many times healthcare administrators never hear it. It is the issue of having your questions not addressed. It is the issue of saying, oh, that doesn't matter, without further explanation. And it is also the issue of limited time to explain, because we're busy putting all of this information into our Epics or other computer systems and not judging body language and having a teach back session with the patient, such that we know if they indeed are understanding what you just explained. Patients interpret this in a variety of ways, such as disrespect, racial discrimination. So I say that only to say that implicit bias training is very important. Physicians may not even be aware of that they're doing this. By definition, that's what it means. So we do also need to make sure that healthcare providers understand this as well. So with that, I'm going to turn it back over to our two speakers, Dr. Green and Ms. Gay, for any additional comments regarding the project. I think I attempted to summarize it, and I'm not going to go back through any of the, Deborah, any of the data or anything like that. If there are questions, we're more than happy to address those questions. But I think you can see at this point, we're looking at the issue from the standpoint of what we see in a particular practice, which is the referral network for level 2 ultrasounds, as well as the issue of transportation.
Question and answer. And then Deborah, so if people have any questions that they want to ask, feel free to type those in the chat, because Deborah's going to monitor those, because we wanted to stop at, like 12:45 to give people questions and an opportunity to ask any particular things. I think one of the things that we just want to say, and Dawn, you may speak about that, when we talked about the transportation, I didn't even realize that it was an issue based on age. So if you want to talk a little bit, Dawn, just quick, like what you found out, I mean, that was important. And what we're finding is that wasn't even on the agenda, but that's specific. But now that's something that we're actually doing now to try to mitigate that going forward. So if you want to just take a second and talk about that.
Sure, happy to do that. So initially,
and I'm sorry, Deborah, can you go back to that slide if you can? The one that was she put up earlier as far as the transportation if you are a minor.
So it's kind of interesting. So when we started looking at transportation, initially first, we wanted to really find out what are people being told even when they get referred to call the hospital and where they need to go. We know transportation is an issue. One issue that we were unaware of is that when the managed care companies were being contacted to transport a patient, it takes sometimes 3 to 5 days to get an appointment scheduled. That's like not really going to help these patients at all, because they are high risk and they need to go right away. That we already share the fact that the distance using PACE transportation is very difficult, but a lot of times, because the way the managed care companies work, you literally, you have to get a patient there, but if they have anyone else that needs to go with them to be able to get to their appointment, they're not allowed to be transported in those cars. So that's really an issue, because many of them will miss their appointment, they will not schedule it, but they will end up in the emergency room, which just does not make a lot of sense, because you're really not taking care of the people that really need to be seen. I also think too, based upon the rulings of what these managed care companies are doing, there are people that need to get transportation access. They're not only missing it, but they are missing it because of the rules that the transportation companies are setting. And a lot of times people don't realize that until it becomes your patient and you're actually so frustrated, and you have to work with the managed care plan that they're covered under. So we want to look at other options as we move forward to see what other alternative options, and to the point where we can actually make legislators understand that this is really a problem that's going to affect the health of both mom and baby. And it's really important that we are probably going to sit there and look at ways that we as a group could turn around and influence change that needs to occur. But the transportation companies are all contracted through the managed care entities that they're covered by. So a lot of times people want to go to a local place, but then they are not working within their plan. And that makes it very difficult for them to have, the services given. So if that helps address some of the issues, listen, this is so deep. And we have history and patient stories that we will actually be able to share. And I think as we further explore this area, transportation is only one of the social determinants. Right. So I think it's really important, and everybody knows social determinants of health, there's many of them. The WHO really describes it as non-medical factors that influence health outcomes. So these are really environments that all of us, where we're born, where we live, where we learn, where we work, where we play, where we worship and age. And it's transportation is the focus, but we also know we are going to learn of other social determinants. But just like you can't do elephant, you got to chunk it and really kind of focus. So our focus is going to start with transportation. And we know as we move forward, we will identify others that will need to be addressed.
One of the questions in the chat, and maybe Dr. Stewart, because you did touch on that, is how are we addressing substance use disorder or overdose prevention, since this is one of the leading causes of maternal mortality? And how do we, and so if you want to address that, and then I can chime in.
Sure. I'm involved in another group. I guess you've probably seen that I'm rather passionate about this area. So I am involved in another group in which we have discussed maternal mental health. And the issue becomes, and I sort of alluded to it earlier, is that we want to reduce the stigmata of having a substance use diagnosis. And if you've ever seen the area of, or been inside a clinic that dispenses methadone, it is not the easiest or friendliest for a patient to work through. There are lines, you have to get there early. Sometimes, and most times that is, there are groups that you must attend. And many of the methadone centers do not want to work with pregnant women because they are by definition high risk. So with that in mind, what we have tried to do, and as I said, this is in another group, is to increase provider awareness, whether you are an advanced practice clinician or physician, about the use of Suboxone. And the good thing now is you don't even need the waiver. So what we did was to put on programs such that one could get information, working with the University of Illinois, information about how to manage and start someone on Suboxone. The state also has some additional information, which is like Doc Assist, which will allow a primary care physician to phone a friend when they're not quite certain about how to do something as it relates to Suboxone therapy. We're also trying to see if there's any interest in doing induction in the emergency room with ER physicians. So those are some of the things we're doing in terms of trying to get primary care physicians, OB doctors included, interested and feeling comfortable prescribing Suboxone. The other thing that we are doing is trying to provide a safe space where women can discuss their problems and perhaps bond and find trusting relationships with both a BH provider, behavioral health provider, as well as a physical health provider, to see that it's for the health of your baby and yourself. This is something you can do, and to give you the support of other women who are similar to you from the standpoint of living in the same community environment? I hope that addresses the question.
All right, there is one other question that's in the chat, and it talks about, are there any considerations for developing systems of maternal care outside the hospital settings within our plan? Birthing centers, home births, midwives, doulas. And I think that is a topic that all of us are addressing right now, not just at Institute of Medicine, but of course you see legislation is becoming, is changing toward a favorable towards, because you also have to, it's great having the service, but the service has to also be reimbursed. And so, Dawn, you may be able to add to that for a little bit, but that is the direction that our state is going now, is to ensure that we're able to partner with doulas, with midwives, and there are 2 people that are working on doing a birthing center. So it's though that movement of getting to put structures in place that allow networks to be able to collaborate together within the various communities to be able to reach these patients and give them other options that are still in a safe setting. But again, there's a lot of movement. Now, this particular group, was it one of our priorities on the list? It was not one of the priorities. However, what you will know is, just like we found out the transportation issue, we're not waiting 9 to 12 months. We've already started on that work. So as we see and information comes out sooner than that, then we're engaging in those conversations that we hope will eventually lead to change. You want to add to that, either Dawn or Dr. Stewart?
Yes. The question really was about developing systems. There are birthing systems currently, but the problem is there are not that many. You have to be certified, and it has to be, for some women, a covered benefit of their insurance plan. So I'm just showing you some of the barriers. The University of Chicago has one. I believe Northwestern, as well as Advocate, the 3 big ones. The others, I believe there are another 3, but they're in the suburban areas. And there's also Illinois Masonic that I left out. So it also has to be a covered billable service. Home births, from that standpoint, and doulas, the commercial insurance plans do not always pay for doulas, just to let you know. And now HFS does have doulas listed. However, a little bit of confusion about what their certification process must be for reimbursement. As you probably are aware, there are a multitude of certifications that are out there. So which ones must an individual have such that the service is reimbursable? I'm not familiar. It's not really spelled out. And with midwives, you asked about, there's another problem in terms of freestanding facilities. Most of the midwives work in conjunction with facilities or OB practices that are like, say, the University of Chicago. It is within their group. So that we don't have readily available, say, freestanding midwives for many women. I hope that answers your questions.
I too can add one point too. I think with all the changes going on from fee for service to value-based care, I think your question is very relevant in that we will explore as we learn through this process. But again, we're focused on chunking it first to really develop the case. But it's a really important case, what you actually shared and questioned. And I think as we move forward, we welcome those types of questions. So as we move forward on our research, it can expand in the future. But I think it's important, and I think because of population health initiatives throughout the state, with all of the HFS transformation projects, they're looking for change. And that's what's great about IOM. You've got a lot of really smart people that are so committed to the change process and have the research behind it. This is a great initiative, and we're really happy to be part of that. So thanks for your question.
There is, and that actually, the next question actually goes into this, and I think Deborah will be giving some information or emailing people out. Someone asked, what are some of the ways that local CBOs can support your action plan over the next few years? Dawn, I'm going to go that one with you first. So what are some ways that you think that people can partner with us as we're trying to, because you already are going to be reaching out to people anyway to get data that we're going to need to support this work. So if you want to give your feedback.
Sure. So I can tell you CBOs are so important. You know, everybody wants to refer to CBOs, but if there's a major issue, you need to get paid for the work that you're doing. When there are grants available, that's awesome, but the grants go away. And then what do you do for sustainability purposes? So I think the CBOs here in Illinois, we have ways through social care management to connect, because this is all about developing communities with a local focus. And it's going to be really important for us to really include CBOs and find ways to bring money to them so that they can be part of this process.
Awesome. Dr. Stewart, anything else you want to add?
There is another question.
Are
It
there any
says,
specific outreach programs for teens?
what I didn't mention that I wanted to talk about is that one of the different ways in which some organizations are trying to improve outreach, there, especially when you speak of teen pregnancies, one could consider centering pregnancy. This model developed over 30 years ago, and its success rate was greatest with young moms, very young moms, because of the community relationship built. The other thing is, I am not sure of any other specific outreach to teen moms other than you do know that the education system, I believe it's Simpson Academy, is a school for parenting and pregnant teens. But outside of that, I am not aware of any specific organization that actually tries to reach teenage moms.
No, and I would just echo what actually you both said. As far as the CBOs, I think as a nation, as we're leading to lending itself to value-based care, all of these partners that you need have to now be written in as part of the system and not part of a grant, right? Because in order to make them sustainable on an ongoing basis, it has to be that we've made a decision that these are important. And so now how do we prioritize putting a line bottom in our budgets that allow them to be a sustainable part of the process of care that we do, especially as we go to value-based care. And I will echo Dr. Stewart. We have a centering program that we were grateful to partner with Blue Cross Blue Shield, and our providers love it just as much as the patients do. We just had a graduating class recently because it gives them a network where they can actually spend 2 hours. And in that 2-hour window, they're able to connect with the provider, ask any questions, and then what they find out is helping them be their best self-advocate when they go to the hospital. They don't go to the emergency room as much. The outcomes are much better, and they build that relationship not just with the provider, but with the people that they network in for those visits. So I think centering is an example of an excellent way that we can increase education and awareness and decrease some of the risk. I know we are running out of time soon. Is there anything else? Someone just put in the chat a couple organizations that work for teen moms. And I think that one other question, Deborah, is that later on, if people are interested in IOMC and want to figure out, any other information, how to connect us, if you can just put the information in the chat.
And also, if I might interrupt, we've had quite a few questions on birthing center, doulas, etc., home visits. One of the big issues is reimbursements. So this would actually be an entirely different work group that we would need to establish to walk through that and the requirements for individuals to get paid for their services rendered.
And someone just put in the chat, oh my God, I forgot, one of the doctors that works with the initiative with me has a nonprofit, and it's the Puddle program, and it's geared just to educating teen moms. So that is another way of connecting. They asked about a program that was out there. Absolutely, having her services available, because we realized in the work with Dawn that the teens have more obstacles than the people that are over 18. And so we found this out again as we were beginning this process of work, and it's only been a couple of weeks. So I am so excited to see what's going to happen over the next 12 months. And again, is as we find things, we aren't waiting for the 12 months. We're getting ready to begin to knock those out as we can, and then elevate that voice, then to require support from policy, from legislation, then that support the initiatives again, so that they become part of our healthcare delivery system. Again, remember, 1 every 5 days. That's the goal. We want that to 0. 1 in 5 days, and having the fact the majority of them are preventable, that is a major issue. So we've got some great information that has been shared about Lurie's, some information about Roseland that's in the chat for people to connect as well. So we are grateful for those who have come to participate this afternoon for this webinar. You can go back and share the link, with others. And again, the work, we're not done. We're not done till that 1 in 5 is gone. So thank you so much for your time this afternoon. And again, special thank you, Deborah, who, we talk and put things together, but she really, and Institute of Medicine comes together to ensure that we're able to give information that's clear, that's concise, and tools that we can go out the door and make a difference and change with. So thank you so much, everyone.
Thank you, everyone, for joining today. Thank you, all of the speakers, for all of your insights and your knowledge, and especially your commitment and enthusiasm. There's definitely, big areas for improvement here. I just want to reiterate a couple of key points here. If you're interested in joining the Maternal Health and Child Workgroup, please contact the IOMC office at iomcstaff.iomc.org. We'll be glad to connect with you, let you know what is needed in order to be able to be part of the work group. I also want to point out to you the March 10th program. Please look to put that on your calendar to attend it. And we appreciate that. This program has been videotaped, so the video will be available, and it will be on the website in about 7 days, sometimes sooner, but I'll just say 7 days just to be safe, on the safe side. It's open, so you can look at it 24/7. And there's approximately over 30 other videos that are on the IOMC website. So if you go to the homepage, just check for programs and videos. All of that information is accessible to you. We will also write up a short summary from this event, this session as well, just 2 or 3 pages with some highlights. It certainly will not cover all of the details that the wonderful people here today have presented, but it'll give you some access to some of the information. So have a wonderful afternoon and have a wonderful weekend. Thank you again. Glad to be a small part of this with all of you, and we appreciate your time and effort. Take care.